Good evening.
We are live now.
Yeah. Good evening, delegates and participants. Thank you for joining Shield Connect today. And today the topic of webinar is myths and facts on PCOS. And today we have a special speaker from Chennai, Dr. Anitha Thanasekaran. Ma'am will take this topic. I will give a quick introduction of ma'am. Before that, let me give a little bit introduction of our page shieldconnect.in. This is our page shieldconnect.in, where you can find all the different sections are available, like blogs section. If you click on blogs, you will find all the blogs related to our gynecology section, and it has been endorsed by all the speakers and doctors who are connected with Shield Connect. Then there is a webinar section where you can find upcoming webinars and past webinars. So till now we have conducted around 882 past webinars. So you can also go through those webinars. And for upcoming webinars, you just have to register. You have to just enroll here, and you can see our today's webinar. And this is our leader section, where you can find all the profiles of our speakers who are connected with Shield Connect. So you can also go through their profile on this page. And we also have special day pages and newsletter and awareness pages on various various topics. So now let me hand over the session to Dr. Anitha Thanasekaran. Ma'am is a consultant at TSH Hospital in Pudukkottai, Chennai. Ma'am has done MBBS DGO. So ma'am, I welcome you on our platform for today's webinar, and I hand over the session to you, ma'am. Thank you so much.
Thank you. Thank you for your words. Going to share my contents?
Yes, ma'am.
Yeah. Today, the topic is myths and facts on PCOS. Hello, I am Dr. Anitha Thanasekaran, consultant physician, Team Specialty Hospital, Pudukkottai. Myths and facts on PCOS. As you all know, PCOS is a disease which is completely surrounded by myths. As it has a long armamentarium of drugs to treat, it also has an armamentarium of myths along with it. So, treating a woman with PCOS is not easy, simply writing her drugs. It takes a longer time to convince her that she suffers from PCOS, and it takes time for the clinician to take over all myths, to bust her myths and give the facts and convince her. That is the first line of, I think, the first line of treatment in treating a woman with PCOS. With this introduction, let us now go to PCOS. It is not now called as PCOD, it is called as PCOS, aptly called as polycystic ovary syndrome, because it is a syndrome. Although it is associated with hyperandrogenism and infertility early in life, but it is a harbinger of a lifelong condition which can lead to serious sequelae such as diabetes mellitus, hyperlipidemia, endometrial hyperplasia, carcinoma, endometrial carcinoma, central obesity, sleep apnea, etc. So it just doesn't affect the fertility or menstrual cycle in women, but it can lead to various endocrinological pathologies. Hence, it is aptly called as polycystic ovary syndrome. To introduce it, PCOS in short, it is not merely a reproductive disorder, but it is an endocrinological disorder which affects women in their reproductive years. When the women, when they suffer from hyperandrogenism and infertility, it is really distressing to the young women. But these metabolic sequelae that follows this, it eventually plagues the individual. It makes us suffer more in terms of morbidity and mortality. With this short introduction, what is more important is it is really crucial to diagnose PCOS early in its course. Why to do? Because it is imperative not only to recognize it, but we need to delay or arrest its metabolic sequelae that follows. Hence, it is crucial to diagnose early in its course. Additionally, if we diagnose her earlier, we can screen her for the expected complications and we can give her proper and timely management of these conditions. Why should the physicians should know about PCOS? It is just, we can see, we all remember PCOS just it affects only a fertility or menstrual cycle. It is not so. Because a woman who has PCOS, they suffer from infertility, suffer from menstrual disturbances such as dysfunctional uterine bleeding. They are more prone for endometrial carcinoma. They are more or less obese, and they suffer from obstructive sleep apnea. They have a high risk for type 2 diabetes, and they can have dyslipidemia. They are prone for hypertension and possibly cardiovascular disease. Another thing is we should know is that sisters, daughters, and other close female relatives, they may also be at risk. Hence, she may need lifelong therapy, and hence we should make sure that her access to healthcare should be there. Hence, all the physicians should know about PCOS. Coming to the history of PCOS, don't worry, I'm not going to in detail everything about PCOS. PCOS is a disease which are nowadays evolving in the modern era, and we can see each and every woman, even the adolescent girls, they come and say, I have PCOD, I have PCOD, I have PCOD. But I'm just going to give a gist about PCOS. How it has evolved. It was originally described by Steen and Leventhal in 1935. It was strictly seen as a reproductive disorder characterized by oligoamenorrhea, hirsutism, and polycystic ovary morphology. When we do a bilateral wedge resection of the enlarged ovaries, it has helped in normalizing the menses and fertility of the women. Hence, the name polycystic ovarian disease came into vogue. 30 years ago, by research, it was found that these women with PCOS, they had hyperinsulinemia. This is a milestone in the history of evolution, in the research work of PCOS. Research, they have shown that PCOS was associated with a unique disorder of insulin action, as well as there are defects in insulin secretion. Hence, these together, these abnormalities, they conferred a substantially increased risk of glucose intolerance. Hence, hyperinsulinemia play a major role in a women with PCOS. Coming to the epidemiology of PCOS, as we know, it is one of the most common endocrine disorders affecting women of reproductive age. It is seen in almost 8 to 11% of reproductive age group women, and it is the most common cause of anovulatory infertility in women. The anovulatory infertility accounts to about 70 to 80% in PCOS women. And among this, the highest prevalence rate in the world is found among the Indians, and that to about 41% in reproductive age. Coming to this epidemic, PCOS became an epidemic in India. Here, about 117 million patients and more than nearly are suffering from this disease, and the number is still continuously rising. And we can see 1 in every 5 women has PCOS, some other features of PCOS, leading to the prevalence rate to about 41%. These complications of PCOD, as we all know, this infertility, the primary infertility was reported in almost about 50% of women, And the secondary infertility was reported in about 25% of women. When these PCOS women, when they become pregnant, they have more obstetric complications. And there is 3 times higher risk of preeclampsia and GDM. And there is twofold increase in preterm deliveries and IUGR. Other cardiovascular complications, the women, they have twofold increase in myocardial infarction and twofold increased risk for hypertension. The metabolic syndrome, which is associated with PCOD, that is, these women, they have 5 to 10-fold increased risk in developing type 2 diabetes mellitus. Oncologic risk, the women, they have higher risk for endometrial cancer. As we can see, the psychological impacts are more than these metabolic disorders. There is 4-fold greater odds of depressive symptoms in these women. And most of the women are depressed and they are anxious and they have a low quality of life. Such an epidemic in India. How to define PCOS? As we know, there is no universally accepted definition for PCOS. We define PCOS according to various consensus. In 1990, according to the US National Institute of Health consensus, they put forth 2 minimal criteria. So if you want to diagnose her as PCOS, the woman is to have both menstrual irregularity, can be oligomenorrhea, can be due to an ovulation, or she can show features of hyperandrogenism, both clinically as well as biochemically. Clinical features includes hirsutism, acne, male pattern baldness, and other features. Or she can have biochemical features such as the elevated serum androgen levels. When the women have these 2 criteria, when these women have these 2 features, then they can be categorized as PCOS if all the other causes that can cause menstrual irregularity or that can lead to hyperandrogenism is ruled out. So hence it is a diagnosis of exclusion. So we have to rule out all the other causes. They can lead to anovulation or oligomenorrhea. That can lead to hyperandrogenism. And after that, we can diagnose her as PCOS. By this criteria, it is clear there is no laboratory evidence needed, no radiologic evidence is needed. Here, by this criteria, the ovarian appearance is not pathognomic, and the insulin resistance, which is a milestone, is not included in this diagnostic criteria. Here, as we said, it is a diagnosis of exclusion, and PCOS is a heterogeneous disorder. The next consensus is the Rotterdam consensus. It is more used, and it is by the ASRM consensus. It requires the presence of 2 out of the following 3 criteria. Hence, if the woman has oligo or anovulation, or if she has hyperandrogenism, both clinical and or biochemical features, or if she has polycystic ovaries, with the exclusion of other etiologies, she can be diagnosed to have PCOS. All the 3 criteria need not be present. Even if she has 2 out of the following 3 criteria, she can be diagnosed as PCOS. Myths. So treating clinician, she has more responsibility. The first clinician who diagnoses her as PCOS, she is the one. She has to give a clear knowledge about PCOS. Otherwise, if she just give her as PCOS and treat her and send her off, when this woman, when she goes to the next clinician, she will bombard her with questions. Because in the short time, when she has been diagnosed with PCOS and when she goes to her home, and immediately the women surrounding her, they will give her so much They will diagnose as a doctor and they'll give so many false things about PCOS. So when these women, when she comes to the next clinician, she'll bombard her with various questions. So I'm going to put forth most of the common myths, commonest myths. I'm going to give the facts. Myth 1. All women with PCOS have ovarian cysts. You can see when a woman, if you diagnose her as PCOS, what she will ask immediately, ma'am, what is the size of the cyst? Whether the cyst will increase, whether we can do surgery to remove the cyst. This is the commonest question all the women with PCOS will ask. Is it so? Is it this PCOS? Is it equivalent to ovarian cysts? No. Based on its name, many people think PCOS refers to cysts, but this is false. For many women, we can see tiny follicles, and these resemble as a stand of pearls in an ultrasound. These follicles, they may look like small cysts, but actually they are very different. And these follicles, they are not cancerous and they do not cause pain. For all the women with PCOS, they do not have follicles on their ovaries. Hence, we have to make sure, we have to convince her that PCOS is not equivalent to cysts. So ovarian cyst is something different and PCOS is something different. Coming to myth 2. Women diagnosed with PCOS can't have children. Even in the adolescent age group, they discuss with each other and they say, if you have PCOS, you won't be able to have children. Is it so? No. Although PCOS is a common cause of fertility problems for women, but that doesn't mean carrying a pregnancy to term is impossible in these women. She can conceive on their own, or she can conceive with the help of fertility treatments. Simple lifestyle changes and a healthier diet itself can also improve the chances of conceiving. So you have to convince her, even though you suffer from PCOD, you can still conceive. Coming to myth 3, or an irregular menstrual cycle means you have PCOS. What we used to say is when the woman comes with irregular menstrual cycle, immediately we brand her as PCOS. Is it correct? No. PCOS, although it is one cause of irregular menstrual cycle, but there can be so many other reasons. A normal menstrual cycle can range from 21 to 35 days. It can be normal for a woman. So we cannot simply diagnose her as PCOS because her menstrual cycle is irregular. We have to keep in mind other factors such as stress, thyroid disorders, and other endocrine conditions, fibroids, that can lead to menstrual irregularity. Even extreme dieting can lead to an irregular cycle. So before diagnosing as PCOS, we have to rule out all other causes that can cause menstrual irregularity. So we have to do additional tests and examine them completely and thoroughly and diagnose her whether really she is a case of PCOS. Myth 4. Women with PCOS can't lose weight. We can commonly see obese PCOS. So we immediately diagnose her with PCOS, obese women, when they come with menstrual irregularity and hirsutism, we immediately easily will diagnose her as PCOS. What is that? If she can't, whether she can't lose weight, they feel that these women are PCOS. So I cannot lose weight. They used to say like this. Is it true? No. Weight loss can be harder for these women, but it is not impossible. Because these women, they have lowered sensitivity to insulin. This insulin sensitivity resistance makes her prone for type 2 diabetes mellitus. Hence, it makes her difficult to lose weight, even if she was following a healthy lifestyle. But when you have a regular plan in losing weight and with a registered dietitian and endocrinologist, you can help her with weight loss goals. So, PCOS women, they can reduce their weight. Myth 5. All women with PCOS experiences unwanted hair growth. Is it true? Are we able to see all PCOS women with unwanted hair growth? No. Hirsutism, as we know, it is an excessive growth of male pattern hair that appear on a woman's face, back, chest, abdomen, or thighs. Hirsutism usually is an underlying sign of PCOS, but it can be sign of other endocrine conditions that can lead to hyperandrogenism. But it is important to remember that all women with PCOS will have these symptoms. If these women are ethnic race predisposes her, then she may have the likelihood of excess hair growth. So we cannot find hirsutism in all women with PCOS. Myth 6. You need an ultrasound to be diagnosed with PCOS. Even in adolescent girls, even if she comes with features of hyperandrogenism and with irregular menstrual cycle, what we see, immediately we will ask her to do an ultrasound. Is it really needed? No. You do not need to have an ultrasound if you have criteria 1 and 2. That is disorders of ovulation or anovulation or oligomenorrhea with features of hyperandrogenism. In women younger than 20 years, ultrasounds are not really recommended. Hence, we can be sure that irregular periods and hyperandrogenism need to be present for the diagnosis of PCOS rather than an ultrasound finding of PCOD. Myth 7. If you're not looking to get pregnant, you don't have to worry about PCOS. You used to say, really, when a woman, if she has completed her family life, reproductive life, what you used to say is, this PCOS is not going to be much problem. You don't have to worry about it. Is it true? Is it true in sense treating her like that? No. PCOS, they doesn't just affect the women's fertility, but it can have long-term effect on the long-term wellness for the rest of her life. As we all know, these women, they are more prone for type 2 diabetes. They can have increased blood pressure, poor cholesterol levels, sleep apnea, depression, anxiety, and have risk for endometrial cancer. Hence, even the PCOS women in the later part of their reproductive life, they need to be diagnosed and treated to have a better future. Myth 8. Everyone with PCOS is obese or overweight. Although obese PCOS are very common. If a lean woman comes, will we not diagnose her as PCOS? The fact is that what we have in our mind is we have a stereotypical picture of a overweight woman. A woman who is bearded with and a fat, and she's fat. So a bearded fat lady. We have that imagination. But this is not so. PCOS is a syndrome, so it can affect from a lean women to obese women. So lean PCOS women do exist. What is important is that this thin women, you should not overlook her, and the obese women, you should not overdiagnose her. So lean PCOS women still do exist, and we need to treat her also. Coming to myth 9, what is said is that the insulin resistance, which is a pivotal role, plays a pivotal role in PCOS, it causes weight gain. The fact is that the reality is that experts are not sure which causes overweight in women. Many people say it's because of the insulin resistance, but what we have found is that the obesity, it causes insulin resistance than the reverse. So we have to address obesity rather than going to treat insulin resistance. Myth 10. Important thing, every woman who comes with PCOS should be put on birth control pill. Is it really needed? No. Hormonal birth control is a common way by the doctors to treat the menstrual irregularities of PCOS. But it doesn't stop with that and doesn't start with that, because the treatment of PCOS, it largely depends on your end goal. Not all the times the patients will be put under birth control pill, but we have to address their hormonal health more holistically with lifestyle measures like reducing stress and encouraging to have an anti-inflammatory diet, etc. So lifestyle modification is more important than your OCPs. So when you diagnose with PCOS, immediately you need not have to put her on OCPs. So coming to the diagnosis of PCOS in short, in a nutshell, but according to the NIH consensus, it is the patient has both features, both criteria, clinical and a biochemical hyperandrogenism, and with oligo-ovulation or chronic anovulation. According to the Rotterdam criteria, 2 of the 3 criteria, that is either they can have oligo or chronic anovulation, clinical and or biochemical and hyperandrogenism both, or we can have oligo, either of these 2 with polycystic ovarian morphology. According to the American Endocrinological Society 2006, they have put forth new consensus that these women, they have to have hirsutism and the features of another biochemical features of hyperandrogenemia with oligoanovulation and polycystic ovaries. So they have grouped all this, clubbed together all these 3 criteria into 2 criteria, and they come with this consensus by 2006. Coming to the etiopathogenesis of PCOS, going to give a short. Until date, there is no accepted theory as to the pathogenesis of PCOS. Because of the diverse maturity of the findings, it is unlikely that any single factor will explain the entire gamut of changes associated with PCOS. It appears more plausible that many factors can trigger the occurrence of PCOS, some more common than other. Once established, it is a well-perpetuated disease and it continues to grow. It is clear, therefore, that PCOS is a lifelong situation in which possibly genetic factors, the endocrine dysfunction, and the metabolic sequelae play a significant role. Coming to this slide, here you can see this genetics and the lifestyle pattern of the women, which can lead to hormonal changes. These changes, when they are exacerbated by obesity, that occurs low-grade inflammation and insulin resistance and hyperandrogenism in these women. And these changes, they can cause clinical features of hirsutism and acne. They can affect the reproductive health, leading on and menstrual irregularity and subfertility. And this insulin resistance can lead to metabolic syndrome such as impaired glucose tolerance. And these women are prone for type 2 diabetes mellitus, and they are increased risk for cardiovascular disease. When these women have features of hyperandrogenism, or when they suffer from infertility, These women, they have more psychosocial issues. So psychosocial issues are more with this PCOS rather than these diseases. These women, they have poor body image. They see to their body as something not good. They feel as if they are not good. And they have low self-esteem and they are depressed and anxious. So they cannot come to a single conclusion about the pathogenesis of PCOS, single causative factor in causing PCOS. Coming to the spectrum of PCOS from childhood to the postmenopausal years, as we know, the predisposing factor can be genetic factors, and it is also mainly due to the in utero programming of the fetus. When we need to diagnose PCOS in a childhood woman, usually we do not do, but we can diagnose by the level of increased AMH. In the pubertal women, these women, they can present with premature adrenarche. They can show features of hyperandrogenism. They have increased GnRH pulse frequency, and we can see that the AMH level is high and the ovarian volume is also increased. And these girls, they tend to have hyperinsulinemia. What is important is that a normal pubertal girl, she also present with acne. She will also have increased ovarian volume. She will also have irregular menstrual cycle. And there is also this thing, insulin resistance of puberty. So we have to distinguish her from a non-normal pubertal girl. Coming to the reproductive years, these women, they can have most commonly these irregular cycles, features of hyperandrogenism. They suffer from subfertility or infertility. When we do the biochemical research, they have increased AMH, they have increased antral follicle count, the ovarian volume is increased, the glucose tolerance is impaired, and have insulin resistance. But what happens in a normal reproductive woman, as the age advances, the androgen level decreases, AMH level decreases, the ovarian reserve decreases, and the antral follicle count also decreases as age advances. This we have to keep it in our mind. Coming to the postmenopausal years, these women, they have increased risk of hypertension, diabetes, increased level of triglycerides. Even a non-normal postmenopausal women, they have increased cardiometabolic risk factors such as glucose intolerance, adiposity, and hypertension. These things we need to keep it in our mind in treating women with PCOS before diagnosing her also. So we can see various types of women. There are 4 types according to the various consensus. I'm putting forth this criteria, we can come into conclusion. Phenotype A, B, C, and D. What is the importance of these phenotypes? We have to see what type of women we are going to treat. This will show her what to address in a problem. Phenotype A is a woman who have all the features, all the 3 criteria: hyperandrogenism and hirsutism, ovulatory dysfunction, and polycystic ovarian morphology. So all the 3 criteria, if this woman is present in this woman, she is categorized as phenotype A, and she may be a case of severe PCOD. When it comes to phenotype B, these women, they have hyperandrogenism and hirsutism and ovulatory dysfunction, but the ovarian morphology may be normal. According to this phenotype C, these women, they have hyperandrogenism and hirsutism and polycystic ovarian morphology, but they do not have features of ovulatory dysfunction. That is, they do not have menstrual irregularities, maybe. According to the phenotype D, which comes only under this Rotterdam criteria, because out of these 3 criteria, they can have either 2. So here, these women, they may not have any hirsutism features, but ovulatory dysfunction as well as polycystic ovarian morphology is seen in these type of women. Phenotype D women are commonly seen in our clinical practice. a word about PCOS in adolescence because we diagnose at early, even in the adolescent age group. So it is often diagnosed in adolescence. In utero exposure to the fetal testosterone, the hyperglycemia and hyperinsulinemia status in the mother, they help to determine the PCOS phenotype. The risk factors includes if there is a family history, then this girl is also prone to have PCOS. If this woman is overweight, obese, and she is more thin, then she can have PCOS. Exposure to androgens during gestation increase a chance of developing PCOS in the later age. And these women, if they have precocious puberty and they are obese and they have insulin resistance, they can also develop PCOS. So the diagnosis of PCOS during adolescence requires stricter criteria. You can just like that, you cannot diagnose her. You have to have unequivocal hyperandrogenism. You have to have features of ovulatory dysfunction. That is, we all know that when the girl attains menarche, the cycle can be irregular for even up to 2 years. So if the ovulatory dysfunction persists even after 2 years after menarche, then we can diagnose her with PCOS. I'm skipping the PCOS in reproductive age group because it is a vast topic and needs more discussion. Going to the PCOS in postmenopausal women, what we have to have it in mind is that this hyperandrogenism features, they can persist even after menopausal transition. And these women, they can have metabolic alterations and metabolic syndrome even in the menopausal age, in postmenopausal age. And these women, they are more prone for cardiovascular diseases. And these women, what they are saying is that what these features that they have during the reproductive years, they may still have these manifestations even in postmenopausal. So you cannot just overlook a postmenopausal woman. We need to get her history of PCOS if she had PCOS in her early age group. Coming to this etiopathogenesis, yeah, you can see the same slide as previously, which was dealt with genetic lifestyle leading to hormonal changes, leading to increased androgens, hyperinsulinemia, leading to metabolic syndrome, ovarian dysfunction, features of androgenism, and more important, these women have psychosocial issues. What is the epidemiological link in these women? You can see that these women, they have increased risk of type 2 diabetes mellitus by about 1,600%. Such a magnitude of this disease in that women. Also, PCOD increases the risk of GDM by more than 200% when these women become pregnant. And among these GDM women, 60% of them, they tend to develop type 2 diabetes mellitus. Even if they are not gone in for type 2 diabetes mellitus, these women, they show insulin resistance, and it is found in about 65 to 80% of PCOD cases. So such is the burden of PCOS in these women. Coming to the pathophysiology of PCOS, as I said, there is considerable debate on what exactly constitutes PCOS. The key biochemical features that is present in the vast majority of men with PCOS are these two things, that is insulin resistance and the chronic low-grade inflammation in PCOS. An important advance in our understanding of this syndrome has been the realization of the pivotal role of insulin resistance in perpetuating the PCOS status. So, insulin resistance is a central key point in all the symptoms that occurs in women with PCOS. Insulin resistance represents a unifying component of the syndrome, and it is present as a common denominator not only in obese PCOS but also in adolescent girls with hyperandrogenism, and all women with multifollicular ovaries, and even apparently normal women with polycystic ovaries. What is the main characteristic of this insulin resistance is that there is a partial resistance which involves the metabolic activities of insulin, but it does not prevent insulin effect on its receptors in the ovary. That is, the skeletal system, they show the complete features of insulin resistance. But in ovaries, this effect is not completely found, and this effect on the receptors is not affected, and hence this insulin, they mediate these androgen productions in thicker cells. The main effect on the insulin on the ovaries is not only to increase this androgen production, but it is also they derange the regulation of androgen synthesis so as to prevent the downregulation of the LH receptors. This leads to increased production of androgens and estrone, which coupled with insulin effect on this lowering of the sex hormone binding globulin. This results in hyperestrogenism and there is decrease in FSH. So insulin resistant, it plays a role in disrupting this LH-FSH pathway. Another theory that has been put forth is also that the inositol deficiency that can occur in a woman with PCOD, this can trigger signaling this insulin resistance, and they cause a disruption in the insulin signaling. So they also makes her prone for insulin resistance, or they can cause insulin resistance, and insulin resistance when they develop, they lead to this hormonal and metabolic effects. To summarize, when these environmental factors and the genetic factors, when they cause inositol deficiency, which this inositol deficiency makes our insulin signaling deranged, leading on to pituitary dysfunction, leading on to enhanced ovarian androgen production, and leading on to development of insulin resistance, and the cycle continues. This insulin resistance in turn causes pituitary dysfunction, and it is a complete cycle, and hence we need to know how to disrupt this course of PCOD. Coming to the clinical features of PCOS, short, in a nutshell, the gynecological features, as we all know, irregular menses and infertility. The metabolic features includes insulin resistance, obesity, increased chances of type 2 diabetes mellitus, acanthosis nigricans. Coming to the androgenic features, they may have alopecia, hirsutism, and acne. A word about this hyperinsulinemia. PCOS will never be complete without discussing about hyperinsulinemia. We have come across from various slides, it is shown that insulin levels may be increased in a majority of patients with PCOS. What we need to do is we do fasting glucose and fasting insulin, and the ratio is more effective, and it is a simple thing to do. And if the ratio is less than 7, it suggests a hyperinsulinemic state. Also, if the fasting serum insulin level is more than 15, and if the serum insulin level post 75 gram glucose, after giving at 75 gram glucose is more than 25 can, this also shows that she is in a hyperinsulinemic status. So, need to diagnose hyperinsulinemia just to do a fasting glucose to fasting insulin ratio. PCOS awareness. We know most of these women nowadays, college girls, school girls, they know about PCOS. When they come to a treatment, now OPD, they immediately ask, can we completely cure? And their mother, when they bring their adolescent girls, they immediately ask whether we can completely cure our disease. This is the most important thing that we have to instill in their mind, that PCOS can never be cured. But there are treatments, there are medicines which can really improve health and fertility. So what we have to say to her is that we will treat your symptoms, but we will not be able to get rid of your basic pathology. So this thing we should instill in our mind, we should convince her. But if we say there's no cure, immediately she gets depressed. But we should convince her that we can treat her all the features, all the symptoms which she suffers. Hence, we should make her aware that PCOS cannot be cured. So what these girls, what they do, what these women, they will do now, I have got treatment in this clinician for a long time, but she is not able to treat my disease. I still have that disease. This is most common finding when these women come to an explanation. So we have to make sure that she understands that there is no cure for PCOS. Coming to the treatment, as you know, the first line of treatment, the first and the important line of treatment is improving her lifestyle. It is the most important thing rather than going to give an armamentarium of drugs. You have to improve our lifestyle. A simple lifestyle modification can go on a long role, play a long role in treating her symptoms. If the woman is obese, if the girl is obese, advise her weight loss, advise her changes in diet, advise her about the physical activity, exercise. When she is able to do these exercises and do changes in her lifestyle, and she is able to lose weight, this itself will help to reduce the serum insulin and the androgen levels, and hence reduce the risk of glucose intolerance and reduce a risk of going to type 2 diabetes mellitus. So just lifestyle modification is just enough for her, treat for her in the earlier age group. But when comes to pharmacological intervention, even after giving her this lifestyle modification, and if she continues to follow healthy lifestyle, even after that, if she has to have glucose intolerance or dyslipidemia, then we need to intervene her with drugs. We have to keep it in mind that we are just treating the symptoms, and we are not treating the cause. As you know, cause is not much known, but the main basic feature in this is this hormonal imbalance and the metabolic imbalance. The symptoms that occurs because of these such as the oligoamenorrhea, the anovulation, acne, hirsutism, virilism, acanthosis nigricans, the impaired glucose tolerance, obesity. These all symptoms can be dealt with. And there are various drugs available in the market where we can treat each symptoms individually. Here, when the women, they have impaired glucose tolerance or hyperinsulinemia, then these insulin sensitizers like metformin or pioglitazones, they come into role. If they show features of hyperandrogenism, these anti-androgens like spironolactone, cyproterone acetate, flutamide, finasteride can be used. If these women, they have menstrual irregularities, they can be put on OCPs. If they want fertility, then they can be put on ovulation-inducing drugs such as clomiphene citrate, letrozole, and estradiol. Then comes this cosmetic, these adolescent girls, where they are more depressed when they have hair, when they have beard, when they have mustache. What they immediately ask, how to get rid of these? We can go in for laser hair removal, bariatric surgery, and acne therapy, although these are short-lived. Then when these women are over obese, they can be put on LODs and statins. So we are treating symptoms and not the cause. A word about this treating this menstrual disturbance. If this woman, if she has no wish to conceive, we have to give her, but she has menstrual disturbances, then we have to give her medical therapy for interruption of estrogen. As we all know, we use oral pills. What happens in these women is that there is no ovulation, there is no progesterone, hence the estradiol, it is non-fluctuating and it rises, and when it falls down, it causes irregular uterine bleeding, amenorrhea, infertility, and these women are they more prone for endometrial hyperplasia leading on to endometrial cancer. So these women, we can put her on oral pills. These oral pills, they individually they have higher risk for cardiovascular disease, dyslipidemia, and thromboembolic events. And there is chance of type 2 diabetes mellitus with OCPs, but this is dose dependent. Hence, we need to choose a low dose oral pills where this progesterone, estrogen is also low, progesterone, they have very low or no androgenic side effects. So choosing an oral pills that will suit her, that is more important. We cannot put simply on all OCPs in all PCOS women. Now, giving a word, just a word about inositol in PCOS. There are various drugs in the market. Nowadays, they are marketing inositol in such an extent that they are the line of treatment in treating PCOS. Previously, we used to treat them with metformin oral pills. Nowadays, this inositol has come into vogue. And how does this inositol play a role? Is as we have studied earlier, it causes this deficiency, it causes insulin signaling, disrupts this insulin signaling. Normally, what this inositol do is that it causes phosphorylation. This phosphatidyl inositol, it activates the insulin, making it insulin sensitivity. This myoinositol, when it is given, it makes more phosphatidyl inositol available. The phosphatidyl inositol is important for insulin signaling. By various research, it has found that both myoinositol and dichloroinositol is found to be low in PCOS women as compared to normal subjects. Hence, when these women, if they are put forth on myoinositol in the ratio of 40:1, it helps to normalize the insulin signaling, hence normalize the glucose metabolism, hence the insulin resistance diminishes, and this leads to changes in LH levels, and the insulin levels becomes normal, and weight loss also starts. Another thing is that the inflammation that occurs in PCOS women, that has been addressed with this inositol, hence this androgen levels, it comes down to normal levels, and hence fertility is restored, and the menses also becomes normal. When the LH levels also comes to physiological levels, the fertility is restored. So many drugs showing inositol has come into vogue, and according to Cochrane Library, it is also shown that inositol favors live birth rate in PCOS. To conclude, I have just given a gist about PCOS. I have not gone into the depth of PCOS. We know PCOS can be discussed as in a separate conference. I'm just I've given a gist. And as we know, it is a PCOS is a multifaceted condition. So a multidisciplinary approach is needed for all these women with subfertility and anovulation. You need to give a holistic care to increase our success rate of fertility. Simple lifestyle modifications like diet, exercise, and behavioral therapy are the most principal treatment in treating women with PCOS, rather than putting her on armamentarium of drugs. Low-dose gonadotropins can be used as a first-line agent, but when affordable and accessibility are not major issues. We may need to go in for IVF or ICSI if even after continuous treating or even after long treatment of PCOS and the women doesn't become pregnant, there are other factors such as tubal occlusion, male factor, we may need to go in for IVF or XA. With this, I'm concluding this topic about the myths and facts in PCOS. Thank you. Thank you for your patient hearing.
Thank you so much, ma'am, for giving crisp information regarding myths and facts, as well as detailed information regarding the treatment part of PCOS. So let me find the questions from the delegates part. Give me 1 minute, ma'am.
Yeah.
So, ma'am, from YouTube page, we received one question that there is one more myth regarding every woman who has PCOS grows hair where she doesn't want it. Is it true?
No, that has been addressed. Hirsutism is not found in all women with PCOS.
Then,
It's not found.
Yes, ma'am. Then the second question is that how much myoinositol can be taken by PCOS patient to get treated?
That's the ratio is 40:1.
And what is the duration, ma'am?
It can be taken up to 3 to 6 months. And we can see changes within 3 months.
Then the one more question is that how much diet is very important for PCOS patient?
See, diet is really very important to reduce our weight. So you can send that to your dietitian who can clearly give her, according to her BMI, they will really give her diet control. They'll advise her.
Yeah. So, ma'am, if any patient is having a hardcore non-vegetarian food, so do they have to restrict non-veg foods if they are?
No, not like that. But they have to have that diet such a way that they do not gain much weight. All non-vegetarians are not obese. And all vegetarians are not lean.
Yeah. So even diet is not the factor.
Not like that. Not that. That's the thing. That is they need to have these calories that are important, that is needed for that woman according to your physical activity. If she is sedentary and she eats and eats and eats, then she'll become obese. You can't say like that, nah?
Yes.
Yeah. Okay. So dieting is important for these women. Really, really, it is important.
Ma'am, thank you for giving all the answers to the questions shared by the delegates. And we are glad to have you on our platform for today's webinar. And we would like to have more webinars with you on different topics on gynecology section. And we would like to meet you once again on our platform, Shield. Thank you, ma'am.
Thank you. Thank you so much. Thank you for giving me this opportunity.
Yes, ma'am. Sure.
Yeah.